register your attendance and get your CME credit. So take a screenshot, save it for later. All right, so Matt, I'll give you the floor to talk about decompression for stroke.
Thank you. Good morning again. You all see my screen. Excellent. All right. So again, I'm Matt. I'm one of the PGY5 residents here. And I'll be presenting quickly on surgical indications for malignant MCA stroke. I have no relevant disclosures. We're going to start with the case presentation that inspired this talk. This is a 58-year-old right-handed male with no significant past medical history. He had left-sided Bell's palsy in the past, but no vascular history. Turned to the ER with acute left facial weakness, left arm and leg weakness, slurred speech, and a right gaze preference. Ziad, hearing this sort of brief vignette one-liner, what would be on your differential?
I would definitely be worried for some kind of acute LVO.
Yeah, a stroke of some sort. This is a pretty classic sort of stroke presentation. When you hear the FAST, acronym and signs around the hospital, it sort of hits the mark. So what other information, going along those lines would you want, Ziad?
I'd want to know his last known well, if he was on any anticoagulants or antiplatelets. Yeah, those are the two main things.
Yeah, last known well, very important. All the stuff that they always, whenever you get signed out for a thrombectomy or get consulted for a, possible LVO or bleed or whatever, all the stuff that the neurologists have already collected, fortunately. So last known well is very important because time is brain that really dictates, interventions available. Then the modified Rankin scale at baseline, which the table on the right here is the MRS scale. And that's just a functional outcome measure. So anything less than 3 is sort of what's considered quote unquote good, and 4 above is poor or less good. And so their baseline functional status in MRS is often important as to what's available to them intervention wise. This gentleman was fully functional at baseline. His baseline modified Rankin was 0. His last known well was he was at work when this happened. So at 8:10, his coworkers noticed him having these issues, and he came into the ER 45 minutes later. So a pretty rapid arrival. The other sort of very relevant information is their NIH stroke scale, which is a quantification of the symptoms related or attributable to the stroke. This gentleman's was 15, which is pretty high. This is the breakdown from the stroke code that was called, and as expected, points for facial and left-sided weakness. And so with all this information, Ziad, what's the next step?
I'd want vascular imaging, so get a CTA, CT perfusion, and a CT head.
Yeah, exactly. Whenever a stroke code's called, they're rushed to the scanner immediately. They don't always get a CTP. I think that's somewhat less in vogue now than it was a little while ago. But yes, they usually always get non-con and the vessel imaging. What do you see on these the non-con and then the CTA here?
Looking at the CTA, it looks like there might be some kind of right MCA occlusion.
Yeah, you see blood flow on the left, you don't on the right. On the dry scan, you can tell the windowing is not great. This is a Mount Sinai West scan, and the default windowing angers me. But you can see that they're not symmetric, the left and the right side, and there's definitely more blurring of the gray-white junction. On the right side, you don't really see like the insula as well on the right. We often look at non-con stroke CTs as far as their aspect score, which is the Alberta Stroke Program early CT score, which, a high score is better, so it's out of 10. And you subtract a point whenever there's signs of ischemic changes in all the territories sort of indicated here. So this person's aspect was 5, which is pretty low. And then he had a right ICA terminus occlusion with no filling in the MCA or ACA. So he was a candidate for thrombolysis. He got TNK, tenecteplase, which is a relative of TPA, a clot buster, which they're currently using here. He got it 75 minutes after symptom onset, so pretty rapid, door to whatever TNK time. While the TNK was being pushed, he had a clinical seizure and got Ativan for it, but he did require intubation. And he did not have any immediate improvement of his symptoms with TNK, and so he was then taken for thrombectomy. Door needle time was 93 minutes, which is also pretty good, and then 110 minutes since arrival to the ER for his first recanalization. So all those time points are pretty excellent. You can see the initial run here of the angiogram, complete occlusion, the terminus. After 5 passes, they achieved a TICI 2B result. And you see here on the final run, improved flow in the ACA and MCA territories after thrombectomy. They did do a CT, dyna scan at the conclusion, which showed some slight subarachnoid or hyperdensity, as you can see here. And just as a refresher, the TICI score thrombolysis and cerebral infarction score is just a grading of reperfusion after thrombectomy, 3 being full perfusion, 2B is above or greater than 50% of reperfusion. He remained intubated and went to the ICU afterwards, but his exam was still decent. He was following commands on the right side and then just withdrawing the noxious on the left side. He had an immediate same day post-op CT showing some increased edema in the right MCA, ACA territories, mild midline shift, but nothing too alarming necessarily on this sort of immediate, day 1 scan. The following morning, on rounds, his exam remained grossly stable. He was still following simple commands on the right side while intubated. But we got another CAT scan, just given this significant infarct burden on this initial post-thrombectomy CAT scan. And, we see already just in, this was for 12 hours later, a lot of increased swelling and shift. And there's now, at least 5+ millimeters of shift right to left, and a lot of, clearly delineated infarct in the MCA and ACA territories. Given the rapid progression radiographically, even though clinically he was still holding in there, he was taken to the OR that morning for a hemicraniectomy as well as frontotemporal lobectomies. Surgery went well. He was intubated afterwards, but he was still following commands on the right and just posturing on the left. He had a clinical seizure post-op day 1, but that was easily treated with anti-seizure medications being optimized. The immediate post-op CAT scan is this one on the top left here, and you already see a good decompression, really wide craniectomy, improvement at the midline shift. You can see some pneumocephalus from our frontotemporal lobectomy. 4-day out CAT scan here on the top right shows pretty significant, bulging of the infarct in brain out the craniectomy defect, but still no significant midline shift. He had no uncal herniation on the scan. So he continued to swell quite a lot, 4 days out after the initial stroke. And so, you can only imagine how bad this would look if he didn't have the bone off or the space created by the lobectomies. He got an MRI 2 weeks later, finally. He still had a lot of swelling of the brain contents out the craniectomy defect. But you can see on the TWI, there were no infarcts in the contralateral hemisphere or brainstem. And so the surgery was able to spare his dominant hemisphere as well as his brainstem. Ultimately, this gentleman, had trach peg He went to acute rehab. 4.5 months after his initial craniectomy, he came to the office, came to the hospital, and had his cranioplasty done. You can see, again, still pretty significant infarcted territory on the right side. At that time, he lived in a nursing home, but neurologically, he was talking. His trach was he had the speaking valve on. He was oriented ×3, intact on the right side. He was spastic on the left, but he was able to lift his proximal left leg anti-gravity. His MRS at this time was probably about a 5 because he was still dependent on the nursing home. After the cranioplasty, which went well, he neurologically remained stable. He ultimately was able to leave the nursing home and go home to live with his family. So I think as a resident, it's easy to think that hemicranie for malignant MCA edema is something that's been well studied and done forever because we get consulted on it so often, we do it so often with good results. But actually, a lot of the evidence for it is relatively new. In the early 2000s, the mortality rate for these large vessel MCA infarcts, space occupying infarcts, the MCA territory, was quoted as up to 80%. They're pretty terrible outcomes. And so that's why a lot of the studies looking into hemicranie for malignant MCA edema were performed. This is a sort of quick summary of some of the major randomized control trials that came out for craniectomy for MCA stroke, all of which in the 2007 to 2014 range. Very few patients overall, but the data was still pretty striking. So I'll just quickly summarize some of the major ones. Decimal was a trial out of France that enrolled from 2001 to 2005. It enrolled young patients, so between 18 and 55 years old, with a pretty high NIH, above 16. They had to have surgery early, so within 30 hours of stroke symptom onset. They ultimately stopped enrollment early because a pooled analysis with 2 of the other European trials showed a clear benefit to the surgical group. They only enrolled 38 patients before they stopped. They did not find any significant improvement in their primary outcome, which was the functional MRS outcome of less than 3 at 6 months with just the 38 patients. But there was a clear mortality reduction. You can see the Kaplan-Meier curve here is pretty striking, with pretty much a quarter of patients surviving without surgery and 3/4 surviving with surgery. I think that the MRS data is also pretty striking. If you look at the lighter hues of gray here are better MRS, and the surgery group there's an obvious trend towards significant improvement, but just sort of underpowered. The other European trials at that time had similar results. Destiny was out of Germany, same time frame. Similar patient selection, young patients less than 60, early surgery within 36 hours. They also had a low overall enrollment, and this was stopped early due to the significant mortality benefit, especially when pooled with the other 2 trials. They did find in their own data a significant improvement in the functional outcome of MRS less than 3 at 6 months, again, as seen here. The other big European trial that was pooled together was Hamlet. This was in the Netherlands, also with young patients less than 60. Their big difference overall was that they looked at up to 4 days out from stroke, so not necessarily as early decompression. When pooled with the other 2 less than 48-hour early decompression trials, they found a significant improvement in mortality and functional outcomes, MRS, at a year out. However, their overall study looking at less than 96 hours alone did not find any significant difference. Destiny 2 came out a little later, and this was an older patient population, so patients above 61 years old, but still early surgery. A little more robust sample size here. And they did find a significant benefit in both mortality and functional outcomes with MRS less than 4 in their surgical group. However, the results are not quite as striking. The benefit maybe not quite as much in these older patients compared to the younger patients, but still the Kaplan-Meier curve I think is pretty striking. And then Head First was a trial out of North America, which was a little more robust overall. Also had slightly older patients, up to 75 years old. They had a really pretty intense methodology where they screened thousands of patients who fit overall criteria. And then for those who sort of screened in with having a big enough stroke and high enough NIH, if those patients ultimately decompensated, they could then be possibly randomized to the surgical group. They only had 25 patients who were ultimately randomized to either surgery or medical management only, so a pretty small sample size. They also had not necessarily the same early decompression targets. They had 4 days out, and they looked at survival at 21 days. They had a little more rigorous medical management paradigm that had to be followed by all the patients. And so their mortality overall was much lower, both in the medical and surgical groups, only 40% mortality in the medical group alone. Perhaps most important, they found that while there was a decrease in mortality in the surgical group up front, with only 20% mortality versus 40% in the medical group, at 6 months out, that benefit seemed to go away, and the mortality was roughly equivalent between the two. Based on this data, the American Heart, American Stroke Association did put out recommendations in 2014, recommending that younger patients with large MCA territory infarcts who would deteriorate neurologically within 2 days, is effective for decompressive hemicraniectomy. So, they did not the strongest recommendation here, and then they recognize that there's no obvious clear indication or trigger. But I like what they say here. It's reasonable to use decreased level of consciousness from brain swelling as the trigger. A recent meta-analysis of these 7 RCTs found pretty clear benefit for surgery in pretty much any domain, both functional and survival data. And again, pretty striking. The overall mortality without surgery, 75% or roughly, versus only 25% or 30% with surgery. So what were the indications for craniectomy? These are sort of very dense general indications from 2 of the trials here, but in general, these trials looked at younger patients overall. A lot of them looked at less than 60 years old, with large, near complete MCA territory infarct, with or without, an ACA or PCA territory infarct as well. The NIH stroke scale had to be fairly high, pretty much greater than 14 for every trial. And some trials had a slightly higher NIH target for dominant hemisphere infarcts, which makes sense because they're more likely to be affected by aphasia or language issues. So they're going to have a higher NIH stroke scale. And most of them specified there had to be a decreased level of consciousness within the NIH stroke scale as well. And then often they had some sort of neurological deterioration or midline shift indication as well, but this was not standardized. One of the ones that specified how much shift was Head First, which said 7.5 millimeters septal deviation or 4 millimeters of pineal deviation on CAT scan. Just this is sort of very vague indications. It just goes to show that a lot of, even though we have RCTs for this, a lot of this is still not clearly delineated about who necessarily benefits, and people are still looking into this. And a lot of meta-analyses and reviews talking about who would benefit. Our busy stroke service, I think we get consulted for hemicraniectomy watch at least a couple times a month across all the hospitals for patients who fit these criteria. And I would say over half of them, well over half of them, don't get surgery and survive or do okay and without surgery. So it's clear that it's not just a holohemispheric MCA infarct that needs a hemicranie. I think from from anecdotal data, it definitely seems like the clinical neurological deterioration or radiographic deterioration with really significant midline shift early on, as seen in our clinical example here, are the ones who probably, I think, meet the indications for hemicranie. This is a fly through from surgical theater of one of Dr. Shigematsu's hemicranies. I don't think that's the gentleman from the case presented earlier, but I think it demonstrates sort of across the board what most of our surgeons are doing for their hemicranie. So you see the midline incision here, very wide, large decompression all the way down to the middle fossa floor, back behind the parietal boss, a couple centimeters off of midline. So this is a very wide craniectomy. We use the reverse question mark incision often, as you saw on that fly through there. There are other possible incisions and ways to do a hemicranie. This top right diagram, three-part diagram, is from the head first trial. This is how they requested that the surgeons do their hemicranie, with this incision starting sort of retroauricular and then coming down across the forehead, which seems sort of cosmetically not appealing to me, but certainly would give you a wide exposure. They could spare the STA. Some people argue for a teed incision in either of these ways, which also could potentially spare some of the vasculature and blood supply to these flaps. There's a lot of possible debates and variations with hemicranie that are still ongoing. Whether to do a expansile duroplasty or not. Should there be a different threshold for patients with dominant versus non-dominant hemispheric infarcts? The size of the craniectomy, a lot of the hemicranie trials looked at just 12 centimeters as their craniectomy size, or thinking of the more standard 15 by 12 centimeter craniectomy that we think of for trauma indications. You could also add resection of the temporalis for cases of expected significant swelling to give a little more room. And then another thing to think about is when to add, strokectomy or lobectomy. And the data on strokectomy is sparse. It seems to be pretty infrequently published. There's no randomized or large trials on it as there are for hemicranie for ischemic infarct. A lot of this is limited to small retrospective studies or just comments within larger hemicranie for stroke studies. Curtin et al., they published a recent retrospective review of 101 hemicranie patients, and they found that 20% of those had to go back for a secondary strokectomy for still having either significant midline shift or for blowing a pupil after their initial hemicranie. Schweik et al. Out of Germany published a recent series of 12 patients who initially had a hemicranie and had to go back for a secondary strokectomy afterwards, so a second surgery. These patients all had refractory elevated ICP after initial hemicranie. They tended to be younger patients with infarcts in multiple vascular territories, so MCA as well as ACA or PCA territories, and they overall had a higher NIH stroke scale than the decompressive hemicranie alone group from their institution. They did find a statistically significant improvement in functional outcomes at 1 year, with almost 4 times many patients with a good MRS outcome at 12 months. However, they had a high complication rate. Almost half their patients who went back for a secondary strokectomy had some sort of post-op infection, which is a pretty strikingly high rate. They also had a higher rate of shunt dependence, which was statistically significant. They tried to use this data to create a score for who might benefit from strokectomy, with more points awarded for younger patients, multi-territory infarcts, and a high NIH stroke scale. But this has not been validated. They had a high area under the curve when they created it, but it was just created based on their 12 patients. Other people have looked at doing strokectomy alone to spare hemicranie, thinking that a craniectomy itself is quite morbid. And so this is a recent study that published on 15 patients with large MZ territory infarcts who had just a limited temporal strokectomy, where they also went and dissected down to the basal cisterns and just drained off as much CSF as they could from the basal cisterns without leaving a drain behind to try to spare craniectomy. And this is the diagram from their study. You can see the small incision and small opening to try to accomplish this goal. They had no comparison group. They only just compared this to the historical hemicrania data from the pooled hemicrania trials. They had good results. They had one mortality within 30 days, and they had above 50% of their patients with a good functional outcome at 1 year. However, when looking at their own data, comparing the good versus poor MRS groups, they had no significant difference. They couldn't quite outline or explain who would do well and who wouldn't after this limited strokeectomy. And then there's a recent systematic review meta-analysis trying to look at primary strokeectomy, so not these patients going back for a secondary strokeectomy, like in the Schweik study. They found 4 studies encompassing 41 patients, a pretty small overall sample size of patients who underwent primary strokeectomy. Then compared that to the historical pooled hemicrania data from the 3 trials. They found a trend towards improved MRS and mortality outcome with strokeectomy alone compared to the hemicrania, but it was underpowered to meet significance. And again, pretty limited overall sample size there. In conclusion, decompressive craniectomy for large MCA infarcts can improve both functional and survival outcomes, especially when performed on the early side, within 48 hours, and for younger patients less than 60 years old, the data is better. The indication to operate is not 100% clear, but clinical radioactive deterioration seems to be the strongest indication. More delayed craniectomy has a less clear benefit on outcomes, and similarly, craniectomies in older patients have less obvious benefit, but there is still a potential for both older patients and more delayed craniectomies. The addition of a strokeectomy or lobectomy can be considered either upfront during the hemicrania or as a take-back second surgery in cases of significant swelling or ICP elevation. However, the data supporting this is minimal. It seems to be best in multi-territory infarcts, so patients with both an MCA and ACA-PCA infarct. And in younger patients, temporal lobectomy can be considered when there's a large, MCA or temporal lobe stroke. And if there's a concomitant ACA territory infarct, frontal lobectomy can be added and can help, increase the survival and outcomes in these patients. But again, it definitely seems like further study and data is needed there. My references. Thank you all. I'd love to open it up for discussion. I know this is a topic that could be talked about for hours. I know everyone has their own sort of take on hemicrania and lobectomy. So I'd love to open the floor for any questions or comments.
Great. Thank you, Matt. I supervise this, so just want to make it and comment. It is a very controversial topic, and then thank you and very good job that to summarize this in a good way. I was amazed, and yeah, it is really controversial. But at this point, the lobectomy itself for the strokes brain is not so difficult, and if you believe that you can add some benefit, it is one thing that you can add while you're doing the hemicraniectomy. So it's and for the resident noticing the landmark of the brains and going into the interhemisphere, taking the temporal lobe, those are a good opportunity to learn the anatomy as well. So and the technical wise, cutting off the lesion, not the healthy, but the lesion is it's also I think it's part of the good training. So it's a good these are the good case for the residents. And but at the same time, recently, like the stroke evidence is coming up, like low aspect thrombectomy is improving the functional outcome, that those evidence is coming out. So maybe the dark part in the scan also still have some surviving brain cells. Maybe we need to take those into consideration, maybe. So in the future, these things might start changing, but at this point, yes, these are the good case for the resident. And then if you believe that you can do the lobectomy in multiple area strokes case, I think it's a good thing to do. And the case we had had a good outcome.
Matt, that's a great presentation, complex field. Is there data on patient satisfaction in survivors?
There is for hemicranie. Yeah, one of the groups that published one of the European trials has looked at both patient and caregiver satisfaction, and they found that patients and caregivers were satisfied with the outcome. Because there's a lot of ethical considerations about hemicranie. There's a lot of controversy saying, you know, are we just trading like MRS6 for MRS5, debilitated patients? But no, there is some data out there suggesting that patients are happy with the outcome.
Yeah. You know, it's a commitment to a lifelong disability. And it's very hard to make those decisions in the heat of the moment. What, you know, to me, the two most difficult parts of these data are the fact that if you operate on young people, you know, they definitely do better than old people. But that can contaminate the data in the sense that the people who are going to do best are the people who don't need surgery. And so, you know, this came out when we were looking at the outcome of endarterectomies, that if you didn't need the endarterectomy in the first place, your surgical outcome was going to be far better. So that makes it hard. And then the other question is, how young is young? Because there's been data that have suggested it really needs to be quite young. As you point out here, most of the papers you presented are pretty young, but a lot of the strokes are in older people. So that was a comment, but my question is, how young, what is the cutoff age for you to do a hemicraniectomy and counsel the family that there might be a good outcome?
Me personally, I've always thought of 75 as sort of the cutoff here, and I think that's, you know, a little older than a lot of the studies here, but even the older age data didn't really get too many patients in the 80s. You know, a couple up to the 80s. I would think of 75 as the cutoff, but I would counsel probably anybody in the 70s or above that they're less likely to do well. I think this, you know, one that the family really has to think over, you know, what they and what the patient would want. I'd probably be hesitant to offer a hemicranie to anybody in their upper 70s or 80s. But I guess if they had a good functional baseline and the family were adamant, I guess there is data to suggest that, you know, an 80-year-old could, you know, survive, potentially do okay after a hemicranie for a large territory infarct.
Hey, Matt, this is Cappy. Nice presentation. One of the issues I think we deal with a lot in the NSICU is the trigger for going. And I wonder, did you come across any data that looked at sort of just basing the operative decision on the amount of territory involved after the initial stroke, or, you know, any impact on waiting for a deterioration? Obviously, we don't want to do hemicranies in patients that aren't going to need it. But at the same time, I think when we wait, we're also opening up the risk that, you know, the patient pulls a pupil at 2 o'clock in the morning. And then we're probably, if I had to guess, those patients, you know, have lost a lot of the benefit that could have been conferred by an earlier surgery.
Yeah, absolutely. I've had this discussion with you, and I think Dr. Liang as well, that I can remember fairly recently. There is some data out there looking at pure radiographic measurements. There's data to suggest that DWI total infarct territory of 145 I guess it must be millimeters cubed, because centimeters cubed would be huge. Is a good trigger, in that 90, I think it's something like 90+% of those patients will ultimately develop malignant cerebral edema. And you know, a lot of the trials here sort of looked at you know, greater than 2/3 territory of the MCA on CT with signs of ischemia. And there's also there's good data that a large percentage of patients with CT territory infarct of about 66% will ultimately develop malignant cerebral edema. So there is definitely some data out there to suggest that there's radiographic targets we can aim for. But it's tough. I think it's really tough, because there are, I think, a lot of patients who we get consulted for with, you know, hemicraniectomy watch, who have large territory infarcts and don't need surgery. And, you know, all these trials found a higher complication rate in the surgical group, which, I mean, partially is probably because they survived and were able to have complications. But, you know, a craniectomy is not trivial, especially as you get older and sicker. And a lot of these patients are, you know, unfortunately older and sicker. And so I think, in my mind, I think, you know, seeing some sort of radiographic or neurological deterioration, you know, is a reasonable trigger in that regard. But you're right. I think that once is the cat out of the bag, you know, once you start to decompensate, I think the evidence does suggest that you're less likely to do well, because we see here that the earlier surgery patients are going to do better. So if you wait 4 days for the swelling to peak and then them to, you know, blow their pupil or become lethargic, they're probably less likely to do well than if we were to take them somewhat prophylactically a day in. I don't have a good answer. I know that was sort of a run around. But to answer your question, there is some data suggesting that there are radiographic targets where patients are nearly guaranteed to develop malignant cerebral edema if their stroke territory is large enough.
Yeah, I mean, I think, Matt, you know, when I was looking at the earlier trials, like the Decimal, Destiny, you know, all those Hamlet, like individually, none of them really were statistically significant, right? And only until all three of those trials were pulled together did they reach significance. And then when you look at all those trials, a significant proportion of those patients were, you know, wide awake, you know, not even the slightest bit drowsy, that got randomized to, you know, the quote unquote prophylactic hemicranie. You know, I personally, I actually do like the head first trial, you know, the one with the rigorous protocol, if you will. You know, that kind of seems more consistent with what we do at Sinai and the other academic center, right? You have someone who you screen in as a hemicranie watch, but they're wide awake, and then only when they, you know, become more drowsy do you actually start randomizing those patients. Whereas the earlier trials, you got randomized to surgery when you just had an imaging finding of a stroke, but you were wide awake. You know, I think the thing to consider for, I guess, us is, I think it depends on the resources of the hospital that the patient is getting hemicrania at, right? I think if you're in a place where you blow people at 2 a.m., but there's people in-house at 2 a.m. that can open the OR and start things, then I think it's okay to push it a little later to try your medical management, try your whatever hemicranie, you know, hypertonics or whatnot. But if you're in a place where, you know, you blow people at 2 a.m. and you gotta call someone in to Uber in and they don't get in for an hour, I think that's a different situation, you know, so kind of depends on the hospital we're at.
Right, well, I think with that, we're going to move on so John has time to talk about what he was planning to talk about today. But that was great, Matt,
The
and a
stroke is more
great
important.
discussion.
Thank you all.
Be careful. I don't know if our movement disorder neurosurgeons are on the call, but John, I'm gonna give you a quick introduction, and then I'll give you the screen. So John Liang is a assistant professor of neurosurgery and neurology, director of the cerebrovascular neurocritical care PRF program, and director of the Mount Sinai West NSICU. He did his undergraduate work at Stony Brook, MD at Ross, and then the remainder of his training split between Sinai and Jefferson. John is an energetic and and highly skilled neurointensivist. He's going to talk to us today about movement disorders and emergencies that warrant intensive care.
Great, thank you. I'm going to share my screen. Okay. So, thank you, Peter. Oops, sorry, I lost my screen again.
We see it.
It's good? All right.
Yeah.
Yeah, so we're going to talk about movement disorder emergencies, which is something that is not commonly thought of or seen, but it is worth discussing because we see these once in a while. So to summarize, movement disorders, we kind of broadly characterize them into two different categories, right? You're either hyperkinetic or hypokinetic movement disorders. Then you also have the progressive and neurodegenerative. Think of your typical Parkinson's, right, where you have Dr. Gopal come and do DBS and all the movement disorder outpatient. Then you have the acute movement disorders, right, where hopefully you'll be calling one of our graduating fellows to come and help. So let's start with a case. Here is a 63-year-old gentleman with history of epilepsy who's admitted for EMU for seizure monitoring. RT is called this morning for exam change. History has diabetes, hypertension, had a prior stroke 20 years ago with a spastic right hemiplegia, also has a right BKA from peripheral vascular disease. So on exam, this is what we see. He's awake, he's alert, oriented to time, place, person. He's fluent, he can speak, he can follow commands. You see the baseline right hemiplegia, that's spastic. And he just has these movements on the left side that's a little hard to control. And so that's what we have. Any thoughts from the residents on what's going on or what's happening? Is this a seizure perhaps?
Kind of looks like he has hemibolism, at least at the beginning, on the left upper extremity there.
Yeah, spot on. So what do you think is going on for what causes hemibolism?
Usually a lesion to the STN, subthalamic nucleus.
Perfect.
Isn't much going on.
Yeah. So exactly, hemibolism is lesion to the subthalamic nucleus is the classic teaching in all the case report. Although now we kind of know that it kind of can be other places beyond the subthalamic nucleus. It can, usually subcortical, but there are even case reports of it being cortical parietal lobes. Good. And here's a different patient who has something similar. It was his hemichorea, kind of felt to be on the spectrum of hemibolism, but a more milder form perhaps. And it looks like these dance-like movements. And if this gentleman had a left caudate hemorrhage, which is what's resulting in the hemichorea.